Hello, and welcome to the VJ Hem-Onc podcast. We recently attended the EBMT-EHA 8th European CAR T-cell Meeting in Palma de Mallorca, and we were thrilled to be the official media partner once again. This fantastic event brought together key opinion leaders, healthcare professionals, and stakeholders to discuss the latest clinical and translational advances in CAR T-cell therapy. The meeting program included a nurses track, with a number of sessions aimed at providing nurses with the latest insights in the field to enhance patient care. In today's podcast episode, you will hear interviews with several speakers from these sessions. This podcast is part of the CAR T and cellular therapy channel on VJ Hem-Onc, which is supported by Legend Biotech. This supporter has no influence over the production of the content. This podcast is intended for healthcare professionals only. First, you will hear from Eric Ertz, the president of the Hematology Nurses and Healthcare Professionals Group, or HNHCP, who shares insight into the CAR T-cell process from a nursing perspective, highlighting the role of the nurse throughout a patient's CAR T journey.
So in our institution at the University Hospital in Zurich, we see all the CAR T-cell patients before they come, and we are only doing the CAR T-cell therapy in an inpatient setting. So we see a couple of weeks before they come to us for the CAR T-cell therapy, and we have a talk with them about their fears, about the pathways, about the procedure. So in half an hour or sometimes 45 minutes talk with patients and their relatives, we clarify the pathway. We show them the ward, the room, with the overall aim that they have less fear for the therapy. And the impact of this procedure is very high. We receive that from feedbacks from patients. So bridging therapy before CAR T-cell therapy has a huge impact on patients and their loved ones. And sometimes you have to bridge for a long time due to, for example, waiting for the CAR T's manufacturing. So sometimes several weeks. So there it's important that you educate patients properly, that they adhere to their medication, but also the psychological impact of bridging therapy is crucial, that they have enough support to go this pathway. And then they come to our ward for the CAR T-cell therapy. Sometimes, depending on the disease and circumstances of the patient. So is the patient too ill, or is the patient living too far away from the hospital? We do also the lymphodepletion therapy before CAR T-cell therapy in the inpatient setting. And that's a new movement, depending of the disease, depending of the product. Sometimes already patients can leave the hospital after 7 days after CAR T-cell therapy. And sometimes, depending of the circumstances, they are a long time in our inpatient setting. So the main role nurses do have with CAR T-cell therapy, of course, the leukapheresis process, don't forget that, extremely important. And as soon as they have received the CAR T-cell therapy, of course, looking at the side effects. So mainly the cytokine release syndrome, the ICANS, and there it's extremely important that nurses have had a proper education about those side effects, because I think reaction as soon as possible as those side effects occur, that nurses can react soon. I think that's crucial. So education overall is extremely important. So one, of course, the EBMT guidelines are very important. And then we launched last November as Hematology Nurses Group and Healthcare Professionals Group, HNHCP. We launched an update of the CAR T-cell learning program. And inside this book, translated from English in German, Italian, French, and Spanish language, you will find all the actual information nurses need to know to deliver proper care for patients.
We also had the pleasure of speaking with the Vice President of the HNHCP, Mairead Nicanila, who emphasises the importance of the European CAR T meeting for nurses and notes the need for a true collaborative approach to care in the CAR T-cell therapy process.
I think this meeting is really important for nurses working within cellular therapy because anything that advances the education and the knowledge base of nurses working at the forefront of care and working at the bedside, delivering care to the patients. And has been highlighted many times during the meeting. Often nurses are the people that patients get to ask questions. It's where they get their information. And anything that updates the information and gives nurses more information and more knowledge and the ability to answer patients and carers' questions and supply their information needs is really, really important. Collaboration has been a huge theme running through our day yesterday and when we were talking to everybody, and it was really something that came out very much with all the patients and even with the stakeholders that were in the room. Collaboration is really important because we need to be able to deliver care in a method. And what is becoming more and more apparent is the hybrid approach and the hybrid models of delivery of care. So it's not just, it's when you're, particularly if you're a tertiary centre where you have referral centres coming in and patients having to go back very quickly to their referring centres or whatever because to demand and access and accessibility. So collaboration is really important, and often nurses are linchpins in that because they're at a point where the patient feels comfortable in talking to them, but also nurses in other centres are going to approach a physician to ask a question. But the nurse in the centre is the person that is kind of a linchpin with the information giving. And I think that's been really important throughout the thing. And even like Danielle yesterday, when he was doing his talk, you know, the patient saying that when he gave them information, why hadn't they been given that information beforehand? So it's often a place where and that's where nurses are a linchpin in it, but they also have to be part of the thing. They have to be part of the multidisciplinary team because nurses have a much more practical approach to things. So yes, often physicians can get very tied up in the science of it and the thing, but nurses are, how do we practically deliver this care? What do the patients need? What is the best way? Assessing the patient's need. Have they got an appropriate caregiver? If we're going to do an ambulatory model, have they got do you know what I mean? So that's where the collaboration and the linchpin is needed.
Mairead also comments on the changing perceptions of CAR T among patients receiving these therapies, highlighting the role of the nurse in appropriately addressing fears or misconceptions patients may have before and during the CAR T process.
It's becoming very interesting because very early on, with an awful lot of patients, up until recently, as CAR T is moving into second line and first line settings even in some places, and the talk about doing that, the misconceptions have been very much that this is a last ditch thing. So I think patients' perceptions are changing. When CAR T started a number of years ago, it was kind of a last ditch. We were going to do anything, and patients didn't not appreciate the risks. They appreciated them, but they didn't in a way care about them because it was anything for survival. I think it's becoming much more different now because the risks are, you know, from a quality life point of view and what we're going to do. And like one of the sessions we had yesterday was on survivorship and quality of life, that it's not just long-term follow-up, but that survivorship and living with and living post these treatments is really important. And that maybe sometimes the stressful element and the anxiety element, and that you're not leaving people post-traumatic stress. And nurses are really important in helping patients navigate that they've often, sometimes at the bedside, you're the person that they're going to discuss this about, you know, I've been given this option, and you need to have the knowledge to do that. So that's where meetings like this, but also education programs like as HNHCP as a group have, where we have our CAR T learning programs, our bispecific learning programs, but also other disease-specific ones are really important, both from in a printed material, but also the e-learning platform that we have are really important to help nurses have those skills and the knowledge to be able to answer those questions.
Next, you will hear from Thomas Yezakel, the chair of the French EBMT Nurses Group and an advanced practice nurse within a cellular therapy unit, who discusses the role of social media in a patient's CAR T-cell therapy journey, noting that it can offer both opportunities and challenges.
Today we talk about social media, and actually we have to know that 70% of the world's population has a mobile phone and 73% is connected through internet. And when it comes to high income countries, for example, Europe, between 77 and 79% is connected through social media. So the question is no longer, is it good or not to use social media? The question is, how can we support our patient and their family in this new environment? Because this is creating new communication space around health, but also around treatment, CAR T, of course. So that's why it's very important right now. And indeed, it brings opportunities for patients, especially because it allowed them to have access to online support groups, and they can look for peer support, emotional support, connection. But it brings also a couple of challenges. Sometimes patients reported when they go on social media that it makes them feel discouraged from their own journey. For example, when they hear about someone else's death or disease progression, or when they are looking for unsolicited content like survival curves or the raw reality of treatment, it can be very challenging for them. So as a nurse, we probably have like a moderate role, because we are very close to them during a long moment during their pathway. And we probably can have like these 3 tips. I like to share these 3 tips. The first is to ask them routinely, did you use social media? What did you see on social media? And did you see something wrong? Next time you can take some screenshot and we can discuss about it. And we can also teach them to have like a critical thinking about the content they see. For example, who is speaking? What for? With what evidence? And we have to integrate this like teaching program like routinely, And the last advice is to guide our patient. For example, we can give them a short list of content or like the CAR T Center's website, but also Scientific Society website, and finally Patients Association, which is a major actor in this topic.
Thomas also shares key messages and advice for young nurses entering the field of cellular therapy.
Welcome first in this fantastic area. It can be very challenging as a young nurse because it is very scientifically complicated. But this is also very exciting. And if you are a young nurse, you're going to learn more and more year after year in this area of medicines who brings new evidence like almost every day. And it's very exciting for a nurse to see that. But because it's also very complex, you have to train yourself. You have to go on this kind of meeting. Actually, this is a place where you learn, also where you network with colleagues from different countries. This is a very valuable opportunity for young nurses. As a young nurse, you have to fully involve the multidisciplinary teamwork. You have to work with other healthcare professionals, social workers, psychologists, dietitians, or physiotherapists, which is very important for our patients during their pathway. Not only with the physician, even if, of course, the relation with the physician is very important, but this is my advice also. Involve the multidisciplinary care team. Usually we say that as a young nurse, first you develop your clinical skills. Nursing clinical ability to assess the patient, to perform the care. But and after a couple of probably months, when you are more comfortable, you develop like the more relation skills with the patient, the ability to truly communicate with the patient, to receive their emotions and to guide them through their pathway, which is a very complex pathway.
The European CAR T-cell meeting also included a nurses session dedicated to the best abstracts. To conclude this podcast, you'll hear about one of these abstracts, presented by Gemma Stewart and Ella Weiser, which reported the findings of a retrospective study to inform the frequency of ICE assessment for the detection of neurotoxicity in CAR T recipients.
So we work in a busy hematology unit in Australia where we've seen more than 300 patients who've received standard of care CAR T therapy. And neurotoxicity is a major complication of CAR T therapy. And so we have a lot of experience caring for these patients and being able to identify and recognize the signs of neurotoxicity. But we've also noticed that the patients can deteriorate quite quickly, often in about a fifth of patients requiring ICU admission for severe neurotoxicity. And we conducted a literature review that found that there was no current consensus on how frequently nurses or clinicians should be completing ICE assessments. And so we wanted to create a protocol that helped guide clinicians on the frequency of ICE assessments.
So the ICE assessment is a 10-point neurological test that comes from the ASTCT guidelines. It tests patients' handwriting, orientation, naming of objects, and attention. Patients are a 10 out of 10 at baseline, and if they drop any points, then that's a sign of neurotoxicity. So our recommendation from the protocol is that patients are assessed 8 hourly from infusion. And then if they show any signs of ICANS, the nurse initiates half-hourly assessments for 2 hours to monitor for signs of deterioration. If the patient stabilizes, they can revert to 4-hourly assessments. However, if the patient remains unstable, our recommendation is to continue the half-hourly assessments until they stabilize. The reason we decided to do half-hourly assessment was so that it mirrored our local hospital policies for patients showing signs of clinical deterioration, for example, sepsis. This is the same thing we would do for a different indication, but we've just mirrored it for ICANS.
So we found that for patients who went on to develop severe ICANS, 93% of those patients initially presented with grade 1 ICANS, which was often dysgraphia, so a subtle handwriting change. And we found that those patients deteriorated to severe ICANS with a median of 13.8 hours. So for nurses who are looking after these patients, I guess what I would say to them is to take the handwriting change seriously and pay attention to them, because once that begins, that's when they're at that high-risk period for deterioration. Also pay attention to other subtle signs that the nurses are the best positioned to pick up on. So things like subtle behavioral changes, lack of eye contact, just patients moving around the room differently or behaving strangely, and most importantly, any family or carer concern that the patient is not quite right. We have found anecdotally and through a review of the literature that that's been reported. While it's not captured in the ICE assessment, it's been reported as something that may be associated with ICANS. So trust your nursing senses.
We hope you enjoyed this episode of the podcast focused on nursing insights and updates from the European CAR T-cell meeting. To explore more of our content from this event, make sure to visit vjhemonc.com. Don't forget to follow us on X at vjhemonc to stay in the loop, and subscribe to our podcast on Spotify, Apple, or Podbean so you never miss a new episode. Until next time.